So, welcome to everybody for the last session of EUS Confluence Days 22-21. And we will have again a fascinating session, more for diagnosis than for therapeutic management, like for the two previous sessions. But I'm sure it will be fascinating and very exciting lectures. And so I'm very pleased to co-moderate with Raj Kumar from India, who was with us yesterday. And our two presenters are Christopher Kaur from Singapore and Mujdes Soytürk from Turkey. So I let the talk to Raj Kumar.
Thank you, Professor Mark. It is indeed an honor. I think all around the world, people know Professor Christopher. He has been a person influencing a lot of therapeutic decision-making in endoscopy and one of the pioneers from National University of Singapore. And he will be speaking today on pancreatic cystic neoplasms, diagnosis and follow-up with endoscopic ultrasound. Professor Kaur, to you further.
Thank you very much, Raj Kumar, for the very kind introduction. I'm just going to share my screen now. Please let me know if it turns out all right. Okay. Are you able to see my presentation?
Yes, we can see your presentation.
Okay. Okay, so thank you very much once again for that very kind introduction, Raj Kumar. I just especially want to thank the organizers for, again, the honor of this invitation. So this evening, I'm going to talk about EUS and the diagnosis and follow-up of cystic lesions of the pancreas. Here is the outline. We'll just go through some the variants of cystic lesions that we encounter commonly. Then we'll start talking about standard EUS techniques of imaging, imaging features, and then cis-fluid analysis. The novel EUS techniques, Dr. Pradam Chai did a terrific job yesterday talking about the three musketeers, if you remember, so I'm not going to cover that. And then we will end off by talking a little bit about the role of EUS in the follow-up. So we do know that pancreatic cysts are a very common incidental finding and are present in a significant proportion of the population. There is a variable range, and of course, more and more people are getting imaging of the abdomen done for various reasons, and they're finding these. Now, we do know also that
Christopher, sorry, can you get closer to the microphone, please, because the sound is very low.
It's very loud?
Yes, you can go closer to the microphone because the sound is very low.
Oh, very low. Okay, I think I need to speak up because the microphone is in. Is this better now?
Yeah, better.
Okay. Yeah. All right, so I'll just speak a little bit louder because it's in the headset. The microphone is in the headset. Okay, so mucinous cysts such as mucinous cystic neoplasms and intraductal papillary mucinous neoplasm are a significant subset. And of course, they have malignant potential. But the problem is that not all pancreatic cysts are mucinous, and a significant number of cysts which have no malignant potential at all and may not even need follow-up. However, the differentiation between mucinous and non-mucinous cysts is not easy. So these are all the variants of cysts. You can divide them largely into epithelial neoplastic and epithelial non-neoplastic, and non-epithelial neoplastic and non-epithelial non-neoplastic. But if we were to look at just the most frequently encountered cysts, here they are in terms of the IPMNs, the MCNs, and the serous cystic neoplasm, or SCN, and the pancreatic, the pseudocysts, which are always associated with a previous episode of pancreatitis. But also the other, maybe fifth and sixth most common would be the SPNs, solid pseudopapillary neoplasm, and the cystic neuroendocrine tumors. This is a nice summary table of those 6 most common frequently encountered lesions, cystic lesions. And if you look at the gender preponderance, in general, females are more commonly associated with the MCNs and SCNs. And of course, the SPNs, they are almost exclusively females by 8-1. In terms of the age, the SPNs are almost always the younger individuals as well as female. But if you look at the other lesions, the age range is quite variable, although maybe towards the older age group. And of course, with pseudocysts, can be any age at all. Pseudocysts, again, are almost always associated, whether you know it or not, with previous episodes of pancreatitis, and it can be either acute and maybe less commonly chronic pancreatitis. In terms of this communication with the main pancreatic IPMN, and maybe sometimes seen in pseudocysts as well. Calcifications, we'll talk a little bit more about that when we go to some of the cases, and we will now move to EUS for diagnosis. The imaging features that characterize the cysts can be broken down into these 6 categories, and we will go through them.
Professor Ko, sorry to interrupt you. Your slides are not being seen. Can you reshare your slides?
Oh, okay. Can you see them now? Are you able to see them now? Okay. How about now? I think we've, let me just check. Can you hear me? Because I'm not hearing anything. You can hear me? Okay, terrific. So I'll just carry on. Okay, so imaging features to characterize the cyst, and then FNA to refine the diagnosis. So just quickly go through the imaging features. Location, for the most part, serous adenomas and branch duct IPMNs are more commonly in the head of the lesion, but not exclusively so. Size, of course, is a predictor of malignancy, especially if it's 3 centimeters and above. Now, we look at locularity also as a feature. If it's a single locule, then pseudocysts more likely. Multilocularity in the other 3 variants. Internal structures, microcystic areas, these are aggregations of tiny cysts of less than 2 or 3 millimeters each, usually at least 5 or 6 of them, and with thin wall septa causing a honeycomb-like appearance. And this is fairly typical appearance of serous adenoma, whereas in the branch duct IPMN, the classical description is of a bunch of grapes, and we'll show you a little bit more of it later. Internal structures that we look out for, neural nodules and cyst wall thickness are a feature of branch duct IPM of the mucinous cyst. The definition of thickness would be at least 2 millimeters for a quarter of the circumference. In terms of shape, the MCNs and the pseudocysts tend to be round. The lobulated lesions would be tend to look like a serous cis adenoma, and if they have an irregular contour, then that would be the bunch of grapes configuration of branch duct IPMNs. As you mentioned earlier, pancreatic duct communication is a feature of IPMNs, sometimes seen in pseudocysts as well. Calcification in serous adenoma, that's fairly pathognomonic of a central calcification, and we'll show you. We'll talk a bit more about that later on with when we get to that section. MCNs can show peripheral eggshell calcification, and this may be an indicator of malignancy. In chronic pseudocysts, you may see, or long-standing pseudocysts, that may be seen as well. So moving on to specific features of the four most common lesions, the serous adenomas have four broad variants. The microcystic is by far the most common type, and that appearance is very highly accurate and specific. There is often a central stellate scar. It is sometimes calcified, but it's only seen in up to 30% of cases on CT and less often seen in EUS. The pseudo-solid variant is made up of cysts which are very, very tiny, so the overall appearance is of almost like a solid lesion. The oligocystic variant is less common. The unilocular variant is less common also. And this is a I have quite a few slides from this very nice paper from the Palermo group, which I really highly recommend that you read, which gives you the whole story about cystic lesions in a very nice package. So this A shows you the microcystic appearance here. It can sometimes be off at the side, and we can sometimes have that microcystic appearance in the septae as well. And then this is the pseudo-solid form where the microcysts are even smaller. This is a nice example of a serous adenoma. This was an older individual who was symptomatic with pain and a little bit of weight loss as well. And on the MRCP, you can see that there's a lesion here at the genu of the pancreas with upstream dilation of the main pancreatic duct. And this is seen on the ERCP as well, with no apparent communication with the cystic lesion. And this is the microcystic appearance on EUS in the middle, that stellate appearance, very specific for SCA. Another view here, and this patient eventually went to surgery, and this is the specimen. What about MCNs? The mucinous cystic neoplasms often present as a well-defined roundish lesion, can be single or unilocular, but a little bit more typically, they are multiple large locules, usually less than 5 or 6, and about 1 to 2 centimeters in diameter with septa in between. And typically, there's no communication with the pancreatic duct. The appearance can be described as cyst in cyst. So multiple cysts within a larger cyst, and with that overall round appearance, mucoid content can appear a little bit thick and granulated. We do want to look out for features of invasive malignancy in these potentially malignant cysts, so focally thickened cystic walls or internal septa, a nodule that appears or a solid component, and if there's associated dilation of the pancreatic duct indicating a large infiltration or rapid expansion. In at least one study, MCNs with cancer were either associated with nodules or larger than 4 centimeters in size. As I mentioned earlier, the eggshell or peripheral wall calcifications are fairly characteristic, seen in a minority of cases, but predictive of malignancy. And here you see the round lesions, septated macrocystic components. These cysts are a little bit smaller here, and an overall round contour of the lesion. What about moving on to branch duct IPMNs now? And this is something that we encounter probably most commonly, and they are typically a multilocular lesion with a bunch of grapes appearance. They are, rather than the cyst in cyst aspect or appearance of MCNs, they are cysts next to cysts and causing an overall irregular contour. And so therefore the overall shape is very different from MCNs. And really a very small minority of branch duct IPMNs will have a round appearance. Then these are some of the slightly less common appearances of IBN and branch duct IPMNs. So this is that bunch of grapes appearance with an overall irregular contour on the outside, finger-like projections of the dilated branch duct, and also the clubbed appearance of the branch ducts here. What about the features of malignancy? They are the same. We look out for an associated solid lesion, a dilated main pancreatic duct, intraductal nodules such as this over here and over here, and also for thickened walls and septae as well. And here you can see a thickened wall here as well, and over here. The communication between the cystic and the cyst and the pancreatic duct is an important diagnostic point, as I mentioned earlier. And EUS, although it is operator dependent, can be very useful, especially if the communication is not so clearly seen on axial imaging. We do know that MRI and EUS are equivalent in showing communication between the cyst lesion and the pancreatic duct. So it is a very good way of looking at that. Now, a multifocal nature is seen in roughly a third of IPMNs, and this is unusual in other cystic lesions, but you can see them in some of the rarer conditions like von Hippel-Lindau syndrome, multiple cystic neuroendocrine tumors, or cystic metastases. It is important, I think, when we are evaluating branch duct IPMN to look out for the fish mouth appearance of the major papilla, because it is very characteristic. And with the linear echo endoscope, you can see this very clearly if you look out for it. It's only present in 30% of cases, and almost all of these are associated with either a main duct or mixed type MT IPMN. Now, pseudocysts are going to be round, most often, without internal septation or nodules. The cyst wall thickness can vary. They are seldom multilocular. And one characteristic appearance is the internal debris that you can see, hypoechoic material, which can swirl around and changes in position when you change the patient of the position. And this is highly specific. So what is the accuracy of looking at EUS morphology? It's pretty variable, but the median number is roughly 70 plus percent accuracy. So not ideal, but how do we improve the diagnostic accuracy? Well, you can do a combination, it's been recommended a combination of cis fluid, CEA, cis fluid, lipase or animal lipase or amylase levels, and cytology will provide the highest accuracy for differentiating mucinous from non-mucinous. And this comes from the European Study Group. FNA generally should only be performed when the results are expected to change clinical management, and if the established diagnosis is already established and there is already a clear indication for surgery, it's not necessary. And of course, the further differentiation more accurately done by the three musketeers, which Dr. Pradanchai talked about yesterday. Sorry, I'm not sure why my slide is not changing. Oops, okay. Let me just move back a little bit. Okay, I'm just going to move forward slowly because, and I hope, can you still hear me? Just going to sorry about that. There seems to be a problem with my presentation.
Christopher?
Yes, Mark. I'm sorry.
We have okay. You have a trouble with your computer. Yeah. I see you are reloading. Okay.
Yes. This hasn't happened before. I'm not sure. Okay. I'm just going to not go back so that we don't risk getting held up again. Okay. But okay. So during FNA, what else can be done? If we're going to be doing EUS FNA, we do need to target any finding of a solid component or thickened wall cyst for cytology. It's often asked what are the risks of EUS FNA in pancreatic neoplasms, the risk of complications is relatively low, although a little bit higher than it would be for solid pancreatic lesions. This is a nice pooled analysis was from the European study group, which looked at a total of 1,300 patients, and only 3.4% had adverse event. Mild in 34, moderate in 9, and severe in just one patient. So overall, severe complications only in 0.08%. IV antibiotic prophylaxis, a single shot is recommended. And in general, it is best to just make one pass if possible to reduce that risk. This study from the Harvard group the Brigham group is very well known, and we do make use of these results. Clearly, 192 nanograms per mil of CEA is very specific. And if you look at the subgroup analysis, the accuracy for CEA alone is 79% compared to cytology, which is relatively high, 59%, and just EUS imaging about half. It's also significant, and this is really just for differentiating mucinous from non-mucinous cysts. It's significant also that there was no combination of tests that was associated with a greater accuracy here. So how optimal is the 192 nanogram per mil level? Well, it's been shown by a Dutch group that if you use a higher cutoff level of 800 nanograms per mil or more, this meta-analysis showed that the specificity increased to 98%, however, at the cost of lowering the sensitivity to about 48%. The converse is that the very low levels of CEA of less than 5 nanograms per mil have a very high specificity for non-mucinous cysts. Now, I think we need to talk also a little bit about cis glucose. In recent years, it's been shown to be very useful, low levels being associated with mucinous cysts. And this is a very recently published meta-analysis, which is only in proof form in GIE, showing that if you look at, again, confirming that very low glucose levels of less than 2.8 millimoles per liter was superior to CEA, more than 192 at that level in the Brugge study, in identifying mucinous cysts with a very high sensitivity and a pretty good specificity as well of 0.82, and area under the curve of 0.96 and 0.79 for sensitivity and specificity. So really very, very good results. This study, of course, is a little bit limited by a lot of heterogeneity in the CEA levels, and also there's a limited sample size in the glucose levels that were available. So very high sensitivity, very low false negative, very inexpensive, very small volumes of fluid needed, and everybody can have access to this. So we await larger confirmatory studies to give us more confirmation. So I'm just going to finish off by talking briefly about follow-up, EUS utility of follow-up in cystic lesions, and the data I'm going to show you mainly from the European study group and also from the 2017 revision of the Fukuoka Guidelines. So when we look at the algorithm from the European study group, we'll just take away the surgical cases, and we look on the left side of the algorithm, and we can see that EUS is alternated with MRI for patients who are not needing surgery and those who have just a single indication for surgery and require intensive surveillance. And we start off with every 6 months for first year, and for those with no indications, and then yearly after that. And it's 6 monthly intensive for those with a single indication. And these are the features that we look out for in these cases. When you move to the Fukuoka Guidelines, and these are specific just for IPMN, the surveillance is done via MRCP EUS, and here you can see that the intervals or the modalities are specific to cyst size all the way up to more than 3. And you would have remembered from Dr. Linda Lee's talk yesterday about the details about contrast and harmonic EUS and the utility. And here you can see that this fits in very nicely with the Fukuoka guidelines when you are evaluating mural nodules of whether they are 5 millimeters or more or less in the worrisome features, and also for evaluating thick and enhancing cyst walls. Surveillance of mucinous cystic neoplasms, those who are more than 40 need to go to surgery. If you have 40 millimeters or less and without a nodule or symptoms, then it's MRCP or EUS every 6 months for the first year, then annually. And they need lifelong surveillance as long as they're fit for surgery. Certainly, there is a choice because EUS is more invasive. So this is my last slide. Just to say that the combination of EUS features, conventional fluid analysis, and cytopathology gives reasonable diagnostic accuracy in diagnosing pancreatic lesions. Cis fluid glucose shows promise in differentiation. EUS certainly has a role in the surveillance of mucinous cystic lesions in combination with CT or MRI, and enhanced by the use of contrast in specific situations. Thank you very much for your attention.
Okay, so Christopher?
Yes, sorry about
okay,
the
so thank you for this very complete presentation about follow-up and diagnosis of cystic tumor of the pancreas. And now we move to the presentation of Müjde Soyturk from Turkey, and she's going to speak about autoimmune pancreatitis, and after we will have a common discussion thereafter the live case transmission. So, okay. So, Müjde, if you want to start. Müjde, we do not hear you. Maybe your microphone is closed.
I am very sorry. Yes.
Yeah, perfect. Okay, you can start.
Firstly, thank you very much, Dr. Barrett. And first, it's my pleasure to be a part of this impressive meeting, and I would like to thank the organizing committee for inviting me to this impressive meeting. I will mainly talk about the role of EUS in autoimmune pancreatitis and cholangitis. Autoimmune pancreatitis is a rare form of chronic pancreatitis characterized by the clinical symptomatology of the obstructive jaundice, lymphoplasmacytic infiltration with marked striform pancreatic parenchymal fibrosis, and a response to corticosteroid therapy. As you know, AIP is divided into two types. High serum IgG4 levels can be seen more than 70% of patients with type 1, while less than 10% of patients with type 2. So, type 2 is not associated with IgG4-related disease and is called idiopathic duct-centric pancreatitis. Type 2 AIP is particularly accompanied by inflammatory bowel disease and not IgG4-related diseases. The most common clinical symptoms are obstructive jaundice and abdominal pain in AIP. In a clinical presentation, we must not overlook the symptoms resulting from the involvement of other organs. We have to keep in mind that there is also a completely asymptomatic form of AIP. It's known that making the correct AIP diagnosis is challenging because...
Müjde,
yes.
So sorry, can you click on the full screen, please? For PowerPoint presentation, you see?
Yes.
On the yes, you see on the button full screen for the. No,
Oh, sorry. I will share.
before.
I will share it again. Sorry.
Sorry. Sorry to disturb you, huh? But
Okay.
we have the small screen for the slides, and if you can improve with the full screen for the PowerPoint presentation, it's better.
I will do full
And now
screen.
you
It's okay?
click on the button full screen.
Yes. Yeah. I hit. I did
Okay,
it.
okay. Let it like this. Let it like this.
Okay. Okay. AIP is a rare compared to diseases it mimics, and no single diagnostic test is available. Lastly, and most importantly, price of misdiagnosis can be heavy. AIP mistaken for cancer results in major surgery, while cancer mistaken for AIP results in delay in surgery. It's known that making the making a correct diagnosis is challenging, but several criteria for AIP diagnosis have been published. The first set of criteria was established in 2002 by Japanese Pancreatic Society. These consisted of three main findings: imaging, serology, and pathology. The high sort criteria, published by Mayo Clinic, added other organ involvement and response to steroid therapy. The high sort criteria proposed 5 criteria for the diagnosis of AIP, and these include diagnostic histology, characteristic imaging, elevated serum IgG levels on serological testing, other organ involvement, and response to steroid therapy.
Mujde, the slides, your presentation, the slides is not changing.
Yeah, okay.
You are still on the same slide.
It's a trouble with sharing. I don't know what it is. I will share again. Sorry.
Okay, try to share again. Sorry, but your slides were not changing.
My connection is good, but yes. Did you see?
Yes, we
Yes,
can.
yes. You change the slide. It's okay.
Okay.
Professor, you can try on the top hand side the sharing. On the top hand left hand corner, the third button.
Like that?
Mm.
No.
No, now we have nothing.
Sharing, but I don't know what it is. Can you see my slides?
Oh, yes, stay like this. Okay.
High sort criteria were updated in 2000. Sorry. High sort criteria were updated in 2011 to the International Consensus Diagnostic Criteria, which are similar to high sort criteria, but important to also draw a distinction between type 1 and type 2. According to ICDC, definite type 1 can be diagnosed with surrogate criteria for AIP, not including histology. However, definite type 2 requires histological confirmation. Let's take a closer look at some of these criteria. A high level of serum IgG is one of the most important laboratory findings. A positive serological results for IgG requires a twofold or greater elevation above the upper limit of normal, although values between 1 to 2 times the upper limit of normal are considered level 2 evidence for type 1 AIP. Imaging methods play an important role in the AIP diagnostic algorithm. It can be said that all imaging methods have a benefit in the diagnosis and differential diagnosis of AIP. Abdominal ultrasound is usually the first method used in differential diagnosis of abdominal pain or jaundice. Ultrasound findings in patients with AIP are characterized by a diffusely or locally enlarged pancreas with low echo. A diffusely enlarged pancreas is called a sausage-like pancreas. A typical localized type AIP sometimes shows a hypoic tumor-like mass lesion, making it very hard to discriminate from pancreatic cancer. Some findings that can be seen in CT in AIP are uniform or focal enlargement of pancreas. A sharp outline, homogeneous decreased enhancement, capsule-like rim, which is highly specific for AIP, and diffuse pancreatic ductal narrowing. In this slide, you can see diffuse type of AIP with sausage-shaped pancreatic enlargement and a hypodense capsule-like rim around the body and tail of pancreas. And in this image, you can see the focal type of AIP in the head of pancreas, resembling pancreatic cancer, and definite diagnosis was made after biopsy in this patient. MRI images of AIP show a diffusely enlarged pancreas with distinctive characteristics, such as a low signal on T1 latent images and a delayed enhancement pattern on dynamic MRIs. A capsule-like rim can also be seen, as you can see in this slide. Rcp and Mrcp can be useful adjunct to diagnose AIP. Rcp and Mrcp features of AIP included the presence of a long, narrow structure, which is more than 1/3 of main pancreatic duct, lack of upstream dilatation from the structured portion of the duct, and multiple non-contiguous structures. The endoscopic ultrasound findings of AIP are essentially similar to abdominal EUS, though its higher resolution can provide clearer images of the involved area. No EUS imaging features are described as pathognomic for AIP. The classic appearance is a diffuse enlarged.
Yes. Sorry, but you need to reshare your presentation because we lost our site.
Okay.
I'm very sorry for this technical issue.
I am very sorry. I will share it.
Just if you can reshare. Sorry.
No problem. I try to share my whole screen. Can you see my slides now?
Yeah, perfect.
Okay. EUS in AIP, yes. No EUS imaging features are described as pathognomic for AIP. The classic appearance is diffusely enlarged gland, sausage-shaped gland with hypoechoic, patchy, heterogeneous appearing parenchyma. When a patient has all of these classic features, there's a high probability of AIP, as you see in this image. But patients often are not found to have all of these features, limiting the diagnosis of AIP using EUS. Another pancreatic finding on EUS is a focal hypoechoic, irregular, solitary mass, as in this image. In addition, upstream dilatation of the main pancreatic duct can be observed. The mass may appear to invade adjacent vessels, cause upstream dilatation of the main pancreatic duct, and be associated with enlarged peripancreatic lymph nodes, mimicking locally advanced pancreatic cancer. Also, EUS features of pancreatic parenchyma may overlap with some characteristics seen in chronic pancreatitis, including the presence of hyperechoic foci, hyperechoic strands, and lobularity. Recently, the utility of contrast-enhanced ultrasonography for the differential diagnosis of focal AIP and pancreatic cancer has been reported. The study group comprised 53 pancreatic cancer patients and 27 focal AIP patients. Others found homogeneous contrast agents distribution and absent irregular internal vessels were observed more frequently in the focal AIP group. And others concluded that contrast-enhanced EUS may be a useful non-invasive modality for differentially diagnosing focal AIP and pancreatic cancer. The image above belongs to a patient with focal pancreatitis, while the image below belongs to a patient with pancreatic cancer. And you can see in these pictures irregular and abrupt vessel disruption in pancreatic cancer. EUS elastography is a new technique to distinguish benign from malignant pancreatic masses. In a meta-analysis evaluating the accuracy of EUS elastography for diagnosis of solid pancreatic masses, the pooled sensitivity and specificity of EUS elastography distinguishing benign from malignant solid pancreatic masses were 95% and 67% respectively. And others concluded that EUS elastography is a reliable technique for the characterization of solid pancreatic masses and may be a useful complementary tool for EUS-guided FNA. In a case control study of 5 patients with AIP, EUS elastography showed a typical and homogeneous...
Can you share your slides, please?
Okay. Internet connection is not good enough today, I think. Can you see my slides?
Yes, we can.
I am very sorry.
No, it's not your
In
fault.
this picture, yes.
This is the web connection.
Thank you. EUS elastography showed a typical and homogeneous stiffness pattern of focal lesions and of the surrounding parenchyma that is different from that observed in ductal adenocarcinoma. The use of artificial intelligence in various medical imaging applications has been expanded remarkably, and several reports have focused on EUS images of the pancreas. One of these studies recently published by Maria et al. This study aimed to create an EUS-based convolutional neural network model trained to differentiate AIP from pancreatic cancer, chronic pancreatitis, and normal pancreas, with sufficient performance to analyze EUS video in real time. In this study, a database of still image and video data obtained from EUS examinations of cases was used to develop a CNN. With this aim, from more than 500 patients, more than 1 million unique EUS images were extracted. Others found that the sensitivity of this model in distinguishing AIP from all studied conditions is at least 90%. So, EUS CNM model seems to be a promising application in differentiating AIP from pancreatic cancer and other benign pancreatic conditions. AIP and its subtypes have a histopathological pattern that is diagnostic. Actually, type 1 and 2 AIP share some histopathological features, such as periductal lymphoplasmatic infiltrate and storiform fibrosis. A characteristic feature of type 2 AIP, not seen in type 1, is the granulocyte epithelial lesions. Additionally, pancreatic histopathology shows more than 10 IgG4 positive plasma cells per high power fit in type 1. Histopathology is diagnostic, but not usually available. Papillary biopsy can be helpful, but it's easy, yes, but high specificity, it has high specificity, but its sensitivity is low. Pancreatic biopsy can be taken under EUS guidance or surgery. Recently, a systematic review was published by Chada et al. This article will review the current literature on the role of EOS-FNA and needle biopsy in diagnosis of AIP. In this study, 14 studies related to EUS-guided sample acquisition among patients with AIP were included analysis. Authors found that EUS-guided needle biopsy provided significantly higher adequacy of specimen and higher diagnostic sensitivity compared to EUS-FNA. To summarize briefly, a core biopsy should be performed since FNA provides no reliable information. I will mention about IgG4 sclerosing cholangitis at the second part of my speech. This is a biliary tract manifestation of IgG-related diseases and is defined as a condition with progressive stenosis and destruction of the bile ducts due to diffuse inflammation and fibrosis. The most common clinical symptoms are obstructive jaundice and abdominal pain. More than 80% of patients with IgG-SC show elevation of serum IgG levels higher than the upper limit of normal value. It's clinically characterized by the chronic elevation of cholestatic enzyme levels, elevation of serum IgG4 levels, diffuse or segmental narrowing of intra and or extrahepatic bile ducts with thickening of the bile duct wall in imaging studies, marked lymphoplasmatic and IgG4 positive plasma cell infiltration and fibrosis in histology, presence of IgG4 related diseases in other organs, mainly in pancreas, an excellent response to corticosteroid. The diagnosis of IgG4-SC is based on a combination of these findings. We can use clinical diagnostic criteria of IgG4-SC were established by the Japanese Biliary Association or the high sort criteria, as I mentioned before, which was developed for autoimmune pancreatitis and adapted for IgG4-SC. 4 types of characteristic cholangiographic features of IgG-SC have been proposed based on the region of the structure. Type 1,
Mujdes, sorry, do you think you could finish in 3 minutes?
Yes.
Because of the following live. I'm very sorry.
No,
because
no.
We have to, okay.
Okay, thank you very much for your understanding. In 2 minutes.
This is due to the following live.
Okay.
Sorry.
Type 1 shows stenosis only in the distal CBD, and it should be differentiated from chronic pancreatitis, bile duct cancer, and pancreatic cancer. Type 2, in which stenosis is diffusely distributed throughout intrahepatic proximally bile ducts, should be differentiated from primary sclerosing cholangitis. Type 3 and type 4 shows stenosis in the hilar hepatic bile duct, similar to hepatic hilar cholangiocarcinoma. As you see in the slide, EUS and IDUS can especially be useful in the diagnosis of type 1, type 3, and type 4. EUS and IDUs can display parenchymal and ductal lesions in detail. Therefore, it plays an important role in distinguishing among chronic pancreatitis, AIP, pancreatic cancer, and cholangiocarcinoma. Moreover, EUS allows taken biopsy. Most cholangiographic features are sometimes difficult to differentiate from primary sclerosing cholangitis, pancreatic cancer, or cholangiocarcinoma. Circular and symmetric thickening of the bile duct wall, smooth outer and inner margin, and homogeneous internal echo are most characteristic images of the bile duct for IgG SC. In this slides, you can see on the left, ARCP shows that stenosis of the hilar bile duct. In the middle, EUS shows a hypoechoic uniformly thickened wall circumferentially, and in this image, IDUS shows wall thickness with smooth outer margin in the bile ducts without stenosis. This picture can be called sandwich pattern in some studies. Hyper, hypo, hyper, echoic appearance. As a summary, AIP and IgG4-SC can be difficult to diagnose. EUS and IDUS play an important role in establishing the diagnosis and distinguishing AIP and IgG4-SC from videopancreatic neoplasms. For histologic confirmation of AIP, a core biopsy should be performed, since EUS FNA provides no reliable information. A multidisciplinary team consisting of gastroenterologists, GI surgeon, radiologists, and pathologists is critical in the management of patients. It is anticipated that AIP and IgG4-SC will be diagnosed more accurately in the future as new approaches are developed. Thank you very much for your attention. I am very sorry.
No. We are very sorry for you for the technical issues. So we will have time for the discussion, and now we move to the endoscopic room. And Rajkumar, you want to introduce the operator?
Yeah, I think in view that we are short of time, we will straight away proceed with Professor Gurhan Sisman from Turkey. Professor, you can take over from here and let us know about the case and then the demonstration of the case.
Can you hear me?
Yes, we can hear you.
Okay, great, excellent. And thank you very much for this season. And then today we will do interesting case in Istanbul in Acıbadem University Atakent Hospital. And then welcome to our endoscopy unit. And then firstly, me and my team, we will do this procedure. And then it will be live case. Firstly, my assistant present the case, and then we will do the procedure. I hope so we will do it because it will be so hard for us, but we will try to do everything. Firstly, my assistant, Dr. Didem, present the case, and then we will start the case. Yes, Didem.
Hello, everyone. We will present you a case of 37 years old male patient. He's a football player and also a smoker. In 2009, he had a trauma to the upper abdomen, and it caused acute pancreatitis. Acute pancreatitis was then complicated with pseudocysts, and it required treatment with percutaneous drainage. And since then, since 2009, he had recurrent pancreatitis attacks. Then in 2015, he was diagnosed as chronic pancreatitis. He had much pain, and endoscopic celiac blockage was done, and he used many painkillers, including opioids, but they had limited effect on his pain. A CT scan in March 2020, the tomography showed disconnected pancreatic duct syndrome, and an Rcp was done, but it failed. In 2021, the tomography scan that we have done shown again disconnected pancreatic duct syndrome with dilation of core pericaudal main pancreatic duct approximately 6 millimeters. Here you see the transverse images of the tomography. Here the pancreatic duct is shown with the arrow, and it is dilated in both images. And this is the video of the tomography. And now you can see the dilation of the main pancreatic duct right there. Yes, you can.
And then I will do some summary before to the procedure, and then we try two times retrograde translation for this patient. One we did not successfully, and then because of this reason we choose this way. And then firstly we will evaluate the main pancreatic duct by EUS image, and then we will choose true way, true point to the puncture to main pancreatic duct, and then we will see clearly main pancreatic duct with contrast agent. And then I hope so we will create a tunnel or fistula, and then we will put the stents, plastic stents, 5 or 7 French stent I will choose. But firstly, I will show you clearly main pancreatic duct, and here you can see, and then maybe we will use some color Doppler image. And then also you can see there is a atrophic part of the pancreas, and especially in the distal part. I think it is related to recurrent pancreatitis attack. And then now, firstly, we will choose the true point, and then I think this area will be so comfortable for us because the main pancreatic duct so near to the gastric wall at this area. I think I will do puncture from here, and then I hope so I will show you the main pancreatic duct with contrast agent. Okay, kaldırabiliriz abi onu. İğneyi alayım canım. And then to puncture, we will use the Nightingale needle with Boston. Alayım canım şöyle. Şöyle tut. İbrahim C kolu da seni az sonra bekleyeceğim. Şöyle tut canım. Güzel. Bir Doppler koysan oraya bir şey.
Guran, just what is the diameter of the Versung duct?
Sorry?
What is the diameter of the Versung duct?
In the part, in the distal part, around 6 millimeter, but in the corpus, around 5 or 6 millimeter again, like the same one, the distal part of the pancreas.
Okay.
Color. If the main pancreatic duct more than 5 millimeter, yes, we can choose this method to drain off the main pancreatic duct. Also, this case is so suitable for this procedure, and then I hope so we will do. Firstly, I will do puncture to the main pancreatic duct. Firstly, biraz daha yer alacağım. Aferin.
Professor, which site of puncture will be more suitable since the duct is of the same diameter, duodenum or stomach?
I think stomach. Stomach will be appropriate for you. Yeah. No. Sure. Tamam. Bir koy bakayım bir. Now we will check the pancreatic channel. Also, I want to see you pancreatic juice. Koy bakayım. Bir karşı göstersene bana İbrahim.
Açıyorum.
Açalım.
Aç.
Belki biraz geriye eğileyim. Yok. Kapatsana, kapat. No.
Professor, are you sure you have punctured? It doesn't look like it has entered the pancreatic duct.
Huh.
No.
Bir aç şimdi. No. I didn't see any pancreatic juice. Because of this reason, I will try again. Kapat. Evet. Şey mi yine?
Tekrardan hedef alayım.
Aha.
Evet, aynen.
Bir color koyalım buraya. Koy bakayım bir.
Açıyorum.
Aç canım. Yok. Kapat tekrar.
Kapattım.
Evet, tutsana. Şöyle tut. Aferin. Tut şöyle. Aslında bir Doppler koy oraya. Kaldır. Bir daha Doppler koysana. Kaldır. Biraz yukarıda kalıyor da. Bakayım. Biraz şimdi duvardan yok girmiyor. Yok. Bir denesene açmayı. Bir dene. Yok. No. Kapat.
Kapattım.
Bu kadar basit gözüküyor ama hiç. Girmiyor. Şöyle biraz tut bakayım. Şöyle tutsana. Şöyle. Aferin. Çok.
So you see, it's often the main problem with Versung gastrostomie is to pass through the pancreas and the pancreatic duct because in a lot of time it is very fibrotic.
Yes, exactly. I agree with you.
Yeah, and I asked to the companies to increase the sharpness of the needle because the sharpness is not sufficient to pass easily through the duct wall.
Neyini? I think we have one just 19 gauge needle now, and then I hope so. Yes. Bir bak bakayım. Aç. Yok. İbrahim bir göreyim karşıyı.
It seems that you pass across the wall. Huh?
I think it's related to hard pancreatic tissue. Because of it, I think the needle so hard position, and then maybe we don't reach the channel easily.
You are using an olympuscope.
Exactly. I will try. I will try now.
I saw with the position. Yeah.
Exactly. I will try now.
Yeah.
Çıkar. Bir göreyim karşı İbrahim. Kanala. Bakayım bir. Bakayım yok. Şurası aslında şöyle tut bakayım ben. Şu genişliği biraz büyütsene ekranı Merve. Ha, çok güzel. Şöyle tut. Aferin. Tut canım. Çok güzel. Aferin bir şöyle tut. Bir denesene.
Nearly, you just push away the ductal wall.
Yes,
But
we are
very
in.
close
Okay,
very close to
we
the
are
ductal
in now.
lumen.
Okay, tamam kapat.
You are
Hemen
very close to
kontrast
the
ver.
ductal lumen.
Yes, we are in now and then we will use some contrast now. Ver canım yavaş yavaş. İbrahim karşıyı
Maybe
göster.
just against the duct wall.
Ver canım ver korkma ver. Ver aferin ver devam et devam. Aferin. Aferin biraz daha.
Can we have William view to see how the contrast?
Can we have an X-ray view?
Yeah, of course. You can see clearly X-ray. Okay, yeterli. Biraz su ver.
Yeah, very nice.
Very nice.
Ver biraz su ver. Now we use. Okay, yeter. Now we will use the guide wire, and then I hope so. We will create fistula.
So what kind of guide wire you use?
Ver canım. Sorry?
What kind of guide wire you use?
I think we will use Acrobat.
Acrobat, okay.
Yeah.
0.35?
Exactly, 0.35.
Okay.
Professor, there's a lot of extraductal spread of the contrast here.
Yes, I saw. I will check now. Firstly, maybe we will use the guide wire and then I will check on the screen. Yavaş yavaş yavaş gel yavaş yavaş yavaş yavaş yavaş yavaş yavaş evet gel güzel bir gönder bakayım aydın. Okay tamam az daha git ya. Okay great excellent okay great tamam. Biraz daha gitsene biraz daha. Okay güzel. Okay I think maybe we are in the some side branch maybe.
Maybe.
Tamam. Şimdi biraz
or maybe your guide wire.
Ben biraz çekeceğim şimdi. Dur ben iğneyi çekeceğim yavaş yavaş. Now we will pull back the needle slowly. Bekle. Bekle. Çekiyorum yavaş yavaş. Gayet iyi tasarı.
And you can increase, you can zoom the X-ray image.
Bekle itme. You can see the X-ray image clearly now?
Yes, you can zoom it.
Yes, exactly. Biraz büyütebilir misiniz şeyi? Dur. Bekle şimdi Merve, yavaş çekiyorum. Bekle yavaş.
Because I think you have a lot of contrast flowing out of the ductal lumen.
Tut şöyle.
I think needle is placed right at the wall, and a part of it is contrast is leaking outside.
Bekle yavaş. Okay. Yo, biraz kink yapmışsın zaten orada, güzel. Gördüm, aferin. Yavaş. Çok güzel. Yavaş Merve. Yavaş. Sen karşı İbrahim sürekli bas karşıya. Yavaş. Bekle. Ahmet bekle. Şurayı bir tutun. Heh, aferin. Çok güzel. Yavaş. Aferin. Yavaş. Gözün burada olsun Büşra. Yavaş. Hiç bunu kaybetme Büşra. Aferin. Yavaş. Aferin yavaş. Çok güzel. Aferin İbrahim. Çok güzel. Yavaş. Ben de tamam. Tamam ben de. Al canım. Ha? Ver bakayım ben. Bekle bakayım ben. Bekle şimdi. Karşıda çok fazla şey var. Kontrast bayağı bir dışarıda diye tahmin ediyorum da şurada. Evet, aynen öyle. I think maybe we are in the out of the lumen because there are a lot of contrast agent around the pancreatic channel. But I will check now.
I think you are the slippery of your guide wire alongside the duct wall and not in the lumen of the Wirsung duct.
Yok ya. Aslında biz içeride gözüküyoruz ya.
Because you see all the contrast flowing out.
Ya? Evet ha. Yok iyi değil. Değil. Dışarıda. Yes, we are out of the main pancreatic duct.
Yeah. I think, yeah.
Exactly.
And you do not see any white bubbles inside the lumen of the Wirsung duct. So this is a sign of you are not anymore inside.
Ver bakayım bir daha iğneyi. Çok mu kontrast var onu anlamadım ama. Aslında ilk başta kontrast verdiğimizde içerideydik. Sonra o kontrastlı basınca dışarı çıktı.
So my proposal is while you are working, not to have any stress for you, we can maybe ask some question because we have only 10 minutes more for the session. So maybe while you are working, Goran, we will speak and ask some question to the previous presenters. And Rajkumar, you agree with that?
Yes, I agree with you. Till the time they can,
Kontrast tamamen pankreasın arkasında duruyor. Sıkıntı.
Okay, so we ask to Christopher and Mujdes if we have some questions.
Bak şurada, gördün mü? Kontrası burada.
Professor Muse, while listening to your lecture on autoimmune pancreatitis, I was wondering why these two diseases, type 1 and type 2, are clubbed together.
Sorry.
They are different clinically.
Sorry, could you repeat, please? I cannot hear you.
Okay, can you hear me better now?
Yes.
Okay.
Very clear.
I was just wondering why these two diseases, that is type 1 and type 2 autoimmune pancreatitis, are clubbed together. Clinically, they are different. Endoscopic appearance is different. Investigations are not supportive. Histological appearance is different. They look to be two distinct clinical entities.
Kontrastın hepsi pankreasın arkasında kaldı. Retroperitona gitti daha.
Yes, you're right. But these are autoimmune diseases, common same based autoimmune properties. For example, histological findings are similar in the two types. For lymphoplasmatic infiltration, storiform fibrosis can be seen in both of them. And it has been proposed that these two types of autoimmune pancreatitis can be occur in the T helper 2 and the T regulatory cell based, and maybe further studies. We need more studies for autoimmune pancreatitis. It's very rare diseases, and
full contrast.
It will be defined these two entities different. I don't know, but common these. I cannot speak very well, but because I hear the voice of Gürhan, I'm very sorry. That's all. Yes.
Okay, just a remark. When you look to the surgical study about pancreatic duodenectomy, we have still about 10% of patients with benign disease, either pseudotumor due to autoimmune pancreatitis, serous adenoma, or things like that. So this session is very important to try to decrease the rate of benign lesions resected by pancreatic
Merve şurayı görüyor
duodenectomy.
musun? Bak şurası full şey.
Professor,
Ya olgunlaşacak,
About
boşaltacağız.
pathology for autoimmune
İçeri gitti yani
pancreatitis.
kontrast oldu.
So, do you use immunostaining for EDG4 with your FNB or not?
Yapacak bir şey yok işte, bazen böyle oluyor.
Actually, we consider
Görüyor musun?
the possibility of autoimmune pancreatitis in all patients with
Bitirmemiz
obstructive
lazım yani.
jaundice and
Tabii.
abdominal pain. Otherwise, we cannot diagnose them. We use always
İşte buraya diren takacağız yani. Ya da
histochemical
kendimize.
staining. If we
Yok, yine eğitirmeye gerek yok yani şu anda
there is a
kontrast arkaya
suspicion
verdik
of
de.
sorry.
Ya onun
If there is
organize
a
olacak
suspicion
yani.
of autoimmune pancreatitis.
Okay.
You're right.
Okay.
But we should do a core biopsy because FNA is not reliable in the
No,
diagnosis
FNA
of
is not
AI.
sufficient. Yes, we told in the previous session that we have not to do any more FNA for solid pancreatic tumor, only FNB, and especially for autoimmune pancreatitis. The diagnosis is very difficult because you have a lot of fibrosis, some lymphocytes, but not so much, and also we need immunostaining if it is a type 1 autoimmune pancreatitis. So clearly only FNB. And this is the good take-home message. If you have any suspicious of autoimmune pancreatitis, use FNB. And I have a question for Christopher. Christopher, we have a lot of patients that will follow with side branch IPMN. So how do you follow really with MRI, with EUS, and how long do you follow these patients?
We have been following our patients with MRCP, MRI, MRCP, because partly because EUS is invasive, they don't want to do a scope unless it's really necessary. And generally, it's when we need to do an FNA, we don't discharge them if they are mucinous. They don't get discharged. The only time when they are discharged is when they become unfit for surgery.
Şu anda bu görüntüyü Ahmet ekrandan bir kaldırsana. EUS görüntüsünü ver.
To go ahead with further follow-up. But that doesn't happen very often.
Şurayı.
Okay.
Is that the same in your practice?
Yes, it's the same. I follow the patient with MRI because it's less aggressive, of course. And when I have any change, I move to EUS examination.
Right. We tend to observe EUS only when we find something that needs to be interrogated. For example, mural thickening, mural nodule, or at the initial diagnosis to distinguish between mucinous and non-mucinous.
Professor Kaur asking about this. Whenever I'm doing an cystic lesion, I'm always worried about the infection despite antibiotic thing. So how confident you are that during the follow-up or in the initial stages when there are some doubtful mural lesions or not very clear signs of malignancy, or then you cannot differentiate, how easily you puncture the cyst, or what exactly would you take the precautions so that you do not go wrong in these circumstances?
I'm sorry, there was some interference from the scope room, the voice from the scope room. Is the question about infection?
I'll repeat the question. See, basically, I'm very worried about infection. When there are doubtful signs between the malignancy and the non-malignancy, and I'm not sure whether I should puncture the thing. If I have a mural nodule, I know clearly I need to puncture. But if I don't have, should I puncture? Should I not puncture? Despite antibiotic prophylaxis, the risk of infection remains. What do you do?
Well, the risk of infection drops to under 5% with antibiotic prophylaxis. But the other thing that I was taught to do early in fellowship was to limit your puncture to just one pass. In other words, do everything in that one pass so that your needle contamination is minimized.
Çünkü çok kontrast
So in
var
other
arkada.
words, if there is a solid area or a thickened wall
Ben konuşayım yani söz versinler öyle
to sample,
söyleyeyim.
then you aspirate all the fluid out first. That goes off for your analysis and for your cytology, cytospin rather. And then with what's left, the solid, the cyst wall has collapsed, the cavity is collapsed, and then you're left with whatever solid, and then that's where you do the FNA, and then you pull out and try not to go in again.
Okay, Christopher, just one. Sorry, 1 minute. We go back to Goran Sisman.
Yes.
Because I think he has something to say about the procedure.
Yes, but maybe we will change our treatment modality because of there are a lot of contrast agent in the retroperitoneal area, and then I saw it by EUS image, and then because of this reason, maybe we will use some radiologic drainage or maybe any other option for the treatment. Because of this reason, I want to cut this case.
Okay. But I think this is a very good take-home message. There is one time where you have to stop a procedure when you take too much risk for the patient and the balance benefits risk is not good. I think you stop at the good time for being efficient for the patient and not dangerous for the patient.
Yeah. Yes, I have to think about the patient.
Yeah.
Exactly.
You're right.
Thank you very much.
Well, no, just to comment about the sharpness of the needle, and I told you, I asked to the companies, the sharpness of the needle is not so good for doing versungasostomy because the duct wall is very hard, very fibrotic, and sometimes it's very difficult to pass through, and you are pushing away the pancreatic gland and not passing through the duct wall. What do you think, Goran?
Exactly, I agree with you. Maybe next time, maybe the type of the needle will be so important for this case. And then also, if you choose the true point to the puncture, for example, maybe distal part of the virsung or pancreas, it will be good for us. But also, this patient has a large diameter of the main pancreatic duct. But firstly, we did the puncture of the main pancreatic duct, and then I think it was fail. Because of this reason, I want to cut here.
Yeah. I think you see, Goran, when I saw the US image, I think the tip of the needle was part in the human and part outside of the human. You see?
Yeah.
Because it has a bias, you see? And so you have the part of contrast filling of the versung duct and the part of contrast filling outside of the versung duct.
Exactly.
Yeah.
I saw.
So thank you, because it was very interesting to see your procedure, to see, even if you are an expert, you can have huge difficulties. And when you have to stop, this was very interesting demonstration. So thank you very much, Goran.
Thank you. See you. Bye-bye.
And thank you to your team. Okay, so we go back to the question, Christopher, I apologize.
Sorry, let me just...
Rajkumar?
Yes.
So, have we other questions? Just to comment about the follow-up of the side branch IPMN. We have some series showing that if you have a malignancy rising at the level of side branch ATMM, usually it's after 5 years of follow-up. And in practice, the patients are followed very strictly during the first 5 years, but after they are not so well followed up. And so it's a problem because the main risk is after 5 years. And we have to say that to all the clinicians. What do you think?
Yes, I agree that we tend to get a bit maybe lax when things don't change. But clearly, these patients have a long-term risk, and it's been quantitated at roughly about 20%, 30% risk of malignant transformation in 5 years. The question is who will turn out that way, and we look to size, we look to all the other parameters for guidance, but it doesn't always follow those rules, and I think we just have to follow the protocols of follow-up, that are prescribed in the guidelines. For example, in the Fukuoka.
Okay. Rajkumar, you have some comment or question?
Yeah, I think I agree with you. A simple method to follow up I take is the reverse figure. 1, 2, 3, and more than 3 centimeter, and reversely 2, 1, 6 months, and 3 months in that order. It's simple to remember as to how to go about it. Preferably, while as Professor Kaur said, I'll use a non-invasive method unless and until I have a doubt that we are missing something, where we go on to the invasive method in these circumstances. I have another question for Professor Moe. Professor, in an autoimmune cholangitis autoimmune, cholangitis pictures, especially type 3 and 4, what are the criteria you take it to differentiate it from hilar cholangiocarcinoma? It is extremely difficult, and do you recommend biopsy every patient who comes with a hilar picture?
Yes, thank you, Dr. Wadhwa. IgG4 sclerosing cholangitis is a part of IgG4 related diseases. So, high level of IgG4 and other organ involvement is in favor of IgG4 cholangitis. And IgG4, it's been known that IgG4C is usually associated with autoimmune pancreatitis as high as 80 or 80 to 90%. And if we suspect IgG4 cholangitis, we should look at the pancreas parenchyma at the same time. If we differentiate the IgG4 sclerosing cholangitis, the cholangiocarcinoma, we can use especially EUS and IDUS. And in EUS and IDUS, there are some characteristic findings of IgG4 sclerosing cholangitis. For example, diffuse or segmental narrowing of intra or extrahepatic bile ducts with thickening of the bile duct wall in imaging studies. And additionally, elevation of serum IgG levels and marked lymphoplasmocytic and IgG4 positive plasma cell infiltration and fibrosis in histology can be distinguish these two entities.
Okay, so we are just reaching the end of the session. So I will ask to Rajkumar to make closing remarks of this session, and I will close the the EUS meetings, if you agree.
Thank you, Professor Mark. It has been a very interesting session. We had a lovely talk from Professor Christopher and Professor Moe on a difficult diseases on day-to-day clinical basis. And I'm extremely thankful to the organizers for allowing us to be a part of this session, and of course all the participants who have participated. Without you all, probably this would not have been a successful meet. Thank you, Professor Christopher. Thank you, Professor Moe. And it has been lovely to interact with all of you. Thank you, Professor Mark.
Thank you very much.
Thank you to all of you for this session. And I just want to close this meetings. I think this meeting was very didactic and very helpful for current practice. We try to organize like this. And I think for beginners or even for experts, it was very interesting. We had some very interesting live cases. And I have to say that if you have a failure of live cases, this is very helpful because this is a real life and not always success. Okay, so this is a real life. So I just want to thank for that. I just want also to thank the attendees. I don't know how many they were, but we try to satisfy them. And also, just to finish, I want to thank Mostafa Ibrahim and all his team in Cairo, all people from Asia, from Middle East, from Europe, and from America also. And to finish, I want to thank the companies who help us to build this nice meeting, Fujifilm and Boston Scientific. And I will hope that next year, it will be the end of the COVID, and we will meet together and share around not of course a beer, but a glass of what you want. Okay, so thank you very much, and hope you were pleased, everyone, and thank you for help and for your attention. Bye bye.
Right.